one of my many cliches is the Google moment. What do you find out? You find out dilated cardiomyopathy, you're going to be dead within 2 years.
Yeah.
Because those numbers are still out there, but that hasn't been true since the 1970s.
Okay.
You're going to find about footballers that have dropped dead on the pitch.
Always, yeah.
Yeah, and so, oh my God, I'm going to drop dead on the pitch because so-and-so died from hypertrophic cardiomyopathy or ARVC.
Yeah.
Everybody finds the same stuff.
Welcome to Cardiomyopathy Conversations, the podcast where we talk to medical experts and patients about all things cardiomyopathy, brought to you by Cardiomyopathy UK, the UK's foremost charity for heart muscle disease. In our very first episode, I chat with Professor Perry Elliott, who is a world expert in the field of cardiomyopathies and President of Cardiomyopathy UK, about all things cardiomyopathy. Don't forget, if you enjoy this episode, to hit the like and subscribe button so we can notify you of every new episode. If you want to find out more about cardiomyopathy, check out our YouTube channel at youtube.com/Cardiomyopathy UK, or take a look at our website at www.cardiomyopathy.org. Welcome everyone to the new Cardiomyopathy UK podcast. It's Libby here, and I'm delighted to be here with the president of the charity, and I'm going to say all-round legend, Perry, in the world of cardiomyopathy. It's Professor Perry Elliott, so welcome to the podcast.
Thank you, Libby. Good to be here.
Perry, you've been in cardiomyopathy land quite a while now. I thought it might be interesting for people to know what led you into cardiomyopathy, and what are you doing now? What are your roles now?
Well, so I went to cardiomyopathy, I would say 1993, which is when I decided to go into research, and the plan was never to stay in research. So I came out of medical school, wanted to be a cardiologist. Mm-hmm. I had this romantic notion of being a general physician first before I went into cardiology. Mm-hmm. So I went off and did renal medicine, neurology, a whole variety of just specialties. And then I said, now's the time to go back into cardiology. Mm-hmm. And at that point in my career, I'd made a number of mistakes strategically in how you pursue a career in cardiology.
Really? What were they?
In that I didn't go straight into it.
Okay.
So it wasn't part of the culture, and to some extent still isn't the culture to do your general medicine. But in a way I was following a path which was aligned to my interests, which I love cardiology. I still love cardiology, but I see cardiology in a broader sense. Mm. Multi-system disease, always asking the question, why does this person have disease? Mm. So I ended up getting a research job at St George's, working with Bill McKenna, did my thesis in hypertrophic cardiomyopathy, and then actually the rest is history. I ended up staying as a clinical academic. And as I say to all my fellows, I think being a clinical academic gives you enormous intellectual freedom. Mm. So, people do the jobs, hopefully, that they're best suited for. Mm. But as a clinical academic, you can say, I'm interested in this, and I can do that for 5 years. And if it all goes well, I can continue doing that. Or maybe I want to move in a different direction. And it's very hard to do that, I think, within a frontline NHS job.
And what are you doing now?
So I'm still a clinician. So I still do outpatient-based practice, still seeing the incredible variety of problems that I've always seen in my career. But I also have an academic role, and I'm sort of now director of our Institute for Cardiovascular Science at UC.
So, Perry, really exciting to be doing this podcast. And I think over the course of the podcast, we'll be talking about quite specific things to do with cardiomyopathy. But I thought it'd be really nice if we just laid the ground for our listeners and talked about cardiomyopathies in the round. Okay. So explain to us exactly what is a cardiomyopathy? What does that term mean?
So you can imagine I'm often asked that question.
Yeah.
And at its simplest level, it just means you've got a bad heart muscle. Your heart muscle is not working properly. Mm-hmm. And there are many, many causes to have a bad heart muscle. Some of them are inherited. Many of them relate to common conditions like high blood pressure or coronary artery disease. Some of them are a mixture of the two, but fundamentally it means that you have a bad heart muscle. Strictly, when we use the term cardiomyopathy, we say that this heart muscle is bad because or that it's not explained by the fact that you've got high blood pressure or that you've had a heart attack. And that concept was invented because in the noise of clinical medicine, people present with heart failure symptoms and so on. They happen to have high blood pressure. So it's very easy to say, oh, it must be because this patient's had a lifelong high blood pressure, or it must be because they've got a bit of coronary disease. And the cardiomyopathy was invented to say, well, no, that's not the case. Actually, these people have something which is intrinsically wrong with the heart muscle. They might happen to have a little bit of coronary disease. They might happen to have a bit of hypertension, but that doesn't explain what we're seeing in their heart muscle. And that's cardiomyopathy at that level, I suppose, is a diagnosis of exclusion, but it's basically fundamentally a bad heart muscle.
Okay, and it's kind of an umbrella term, isn't it? And so under that term of cardiomyopathy, there sits lots of different types of cardiomyopathy. And I think often you talk about it being a description of what you see when you scan the heart, and not a diagnosis. But I think maybe a lot of people listening to this podcast will think, but hang on a minute, I've been given a diagnosis of hypertrophic cardiomyopathy or dilated cardiomyopathy. What do you mean it's not a diagnosis? So what do you mean it's not a diagnosis?
So the reason I emphasise that is because saying that you have hypertrophic cardiomyopathy or dilated cardiomyopathy or ARVC doesn't tell you the cause. And in that sense, it's purely descriptive. So since the late 1950s, we've organised this world of cardiomyopathy into whether the heart is thick or whether the heart chambers are enlarged and the contractile performance of the heart is impaired. That's the descriptive element. So in that sense, is it any different from coronary disease or hypertension? No, you could say hypertrophic cardiomyopathy, in that sense, it's a diagnosis. But the problem is, I think in the past, that's where, at least in the medical mind, the thinking has stopped. And I think what we now know in the modern era is that just because your heart's thick, it doesn't mean that everybody's going to behave in the same way. It's going to depend on the reason for that increase in thickness. Dilated cardiomyopathy, the same. In fact, probably dilated cardiomyopathy is more than any of the cardiomyopathies is broken up into a whole range of different diseases. Yes, they can all be characterized by having a big heart and poor function, but how they behave in the long term, what the implications are for management, for families, can be totally different depending on the underlying cause.
Talk to us a little bit about how you go about finding the underlying cause. What's the process of, this person's got, let's say, for example, a thick heart. What's the next step in kind of the why around that?
So for me, it's an iterative process. So it starts as a person comes in and sits down. Tell me about your symptoms. When did they start? How old is that person sitting in front of you? Because that's going to determine the differential diagnosis.
How does it do that? What difference does age make?
So there are some cardiomyopathies that will present exclusively in childhood. Maybe within the first year of life. So a lot of the what we call disorders of metabolism. So you've inherited an abnormal metabolism. It could be in the heart, in the liver, more broadly in the body.
So are kids ever born
with
a thick heart?
Absolutely.
So it's not necessarily something that it could be something that develops, but they could actually be born with it.
Absolutely. And again, it depends to some extent on the cause. So in that first year of life, that's where inherited disorders of metabolism account for a much larger slice. As you get older, they become much less frequent. Go to the other end of the age spectrum, and if the first presentation is in a 75-year-old man with a thick heart, then it's a different differential. It could be amyloidosis, for example, which doesn't affect young people. So the age of presentation is fundamental. And it's when I teach this to medical students and to fellows, I say, who is this person sitting in front of me? Because that's going to help you in making your diagnosis. What do they do? It could be for a living, or is this a 23-year-old athlete? Because if I then look at the tests, the echo, the ECG, then I may have to think about that in the context of, is this explained by the fact this person is an athlete?
So like any other muscle, if you work it, it gets thicker, it gets stronger. It could just be
A physiological
the result
response.
of,
Exactly, yeah.
Yeah, okay.
Yeah. The family history is fundamental. So, if it's family history, oh yes, well, my father had, a thick heart. His brother died suddenly at the age of 52. My grandmother, had a pacemaker.
It's interesting that, isn't it?
Yeah.
Because actually when people say, you say, my father had a thick heart, do people often say my father had a thick heart, or do they say things like, well, my dad used to faint quite a lot, and we just thought it was one of those things. And it's not until somebody that presents to you in the clinic and they're thinking retrospectively that they might actually think, there were maybe 1-2 generations of
Very much
fainting or, blackouts.
Yeah. And that's why when taking family history, if you do it properly, you have time to do it properly. It takes 5-10 minutes, maybe more.
Yeah.
Because you have to draw out the family tree and say, okay, look, talk me through your relatives. So how many siblings do you actually have? So, okay, is this brother okay? Is this one? Is this one? Actually work your way through the family tree. If you just say, is there anybody in the family, you often don't get a very precise answer.
Yeah.
You ask the question different ways. So has anybody in the family had heart problems, or has anybody died at a young age? Has anybody had a pacemaker? Blah, blah, blah. Because you might get different responses.
When you say died at a young age...
What do you mean by a young age? Or?
Yeah. How young is young?
As always, when I answer these questions, it depends. You're probably looking at, so let me rephrase it. So deaths below the age of about 40, particularly sudden cardiac deaths, are more likely to be an inherited condition. So once you get above the age of 35, 40, in the population, the majority of sudden deaths are caused by coronary disease. So the younger they are, the more likely it is that this could be an inherited problem. So people will say, well, and I often ask the question, they'll say, my parents are dead. How old were they when they died? And so it may be 50, it may be 80. Siblings, my one brother died. Well, what age was he? So actually I specifically asked the question, how old were they? And the reason I'm sort of giving you a slightly waffly answer on this one is because you sometimes in some families see clusters of deaths maybe in the 50s.
Yeah.
Well, 50 is not that old. But if quite a lot of people have died suddenly in their 50s, you start thinking, okay, well, is that relevant to what I'm seeing here? I mean, you've heard me say it before, writing in the margin. It's a story that you're trying to tell. And at the end of that story, you say, well, actually, all this sort of adds up to maybe late onset hypertrophic cardiomyopathy. And these people are developing their diseases not in their teens, but in their 40s and 50s. During that early phase of the disease, they're just as vulnerable to sudden cardiac death.
Okay.
It's one of the many stories that sort of emerge when you do that kind of thing.
Yeah.
But what I'm saying is how important every part of that diagnostic pathway is. It all has value. Just the context and the family history may give you as much, if not more, information than an electrocardiogram or an MRI.
I suppose the thing about that is that actually for somebody like you, you're a cardiomyopathy specialist, you're kind of tuned in to that kind of way of thinking. Whereas people might present to their GP or their, general cardiologist who are not tuned into that way of thinking, and they won't go down that path. Do you think that's changing a little bit now? Do you think it's becoming more, I
don't know.
common? Because I think maybe there's a feeling that, back in the day, people you've got hypertrophic cardiomyopathy, pop them on a beta blocker and off you go, I mean, at least now there's the risk calculator to look at sudden cardiac death risk. But I wonder how many people get stuck at that point, and actually how many people would think like a cardiomyopathy doctor would think about it. Yeah,
it's what we call the cardiomyopathy mindset, but it's not peculiar to cardiomyopathy. So again, I've spent most of my career as a clinical academic. Here I am an ivory tower professor, so I can espouse this, counsel of perfection as to how you should assess a history. But I realise in the real world, it's much harder to do that. If you're in a busy A&E department, or if you're a GP, you've got less than 10 minutes to see someone, and here I am saying you should spend 10 minutes doing this very...
And perhaps sometimes people don't actually know. Do you ever come across that, where people don't really know?
You mean healthcare professionals or patients?
No,
or...
the patients. We go, tell me about your family history. And I'm like, well, actually, I can... No?
They may not, absolutely. Or they're adopted or whatever. There's all sorts of pitfalls in that process. But that doesn't matter. As I say, each step you judge on its merits, and it may or may not be relevant. Same as an ECG. An ECG may be completely normal.
Yeah.
But it doesn't mean there's not a clinical problem. But the answer to your question, has it improved? Yes, it has. It has improved. I mean, evidence that that's the case. We did a piece of work a few years ago looking at the electronic health record in the UK, the prevalence of hypertrophic cardiomyopathy as a diagnosis. It's probably underrepresented, because if you look at hospital records, you've got the top of that pyramid.
The people that present.
Absolutely. But if you look over the past 10 years or so, the frequency of diagnosis for all of the cardiomyopathy subtypes has increased substantially. That's not because they've suddenly become more frequent. I think it represents probably better diagnostics.
Yeah.
But I think it also represents a greater openness to actually using the term on the part of clinicians. When I was training, there was still a reluctance to label someone as that.
And why? So why was that? And what's different now? So was it that, in the old days there would be, we don't want to give someone this title because there's not a lot we can do for it, and people saw it as a death sentence. Whereas now there are more things we can do for it. So are people easier with it just because there's more they can do about it?
It's cultural, so I think that's how medicine was done. So, this is the doctor's job. I'll work out what's wrong with you, but you don't. You just do what I tell you to do, sort of thing. Yes. So there was this notion that it was a bit like cancer. That cardiomyopathy, that's a killer disease. So do we really want to worry the patient by telling them this? So we'll give you some tablets and so on, because we didn't. Even when I was training, we didn't have defibrillators.
Yeah.
With 1990s, we started to get transvenous devices. Before then, you'd have to have a...
It's mad to think about that, isn't it? In this kind of, in this current healthcare system that we live in, that actually there was a time when we might not have told somebody that they had a disease, because the decision was that it would be detrimental to their mental health, essentially. Yeah. I mean, that's almost unthinkable now.
And using all sorts of euphemisms to describe disease, but not actually saying what it was.
Yeah.
And I think, when I was training, that was changing the world of cancer. Just say the word cancer, but then explain what it means for that individual. We've had a bit of that in cardiology with things like heart failure. So heart failure. You mean I have heart failure? I'm going to die?
It's such an awful term, isn't it? And what does it actually describe?
In itself, it just means that you've got symptoms because your pump isn't working as well as it should. But that can be for many reasons. It could be because you've just got into atrial fibrillation, which is the eminently treatable arrhythmia.
Could just be because you're unfit.
It could be unfit. It could be a variety of things. The trouble is, we have tried other phrases for that. So there was a fashion for a while of creating heart function clinics. But then people would come to the clinic and say, what does this mean? Do you mean I've got heart failure? So I think it's like cancer. You say, you've got heart failure, but let me explain what that means for you. It doesn't necessarily mean you're going to die tomorrow. It usually doesn't. It means we've got a huge number of things we can do for you. Yeah. And your prognosis is going to be not that bad at all.
Yeah.
So I think it's all about saying, what do these terms mean, and trying to explain as best we can.
I think that term heart failure, so we're going to do a whole other episode about, heart failure, cardiomyopathy, what's the difference, what does it all mean? Because it's quite a scary term.
Of course.
And I think a lot of, you've said this before, but a lot of cardiomyopathy gets caught up in heart failure and goes no further. Yeah. Interesting one, that. So I think one of the things that I'm curious about at the moment is that there are new terms coming up. So things like alcohol cardiomyopathy, diabetic cardiomyopathy, obesity cardiomyopathy. So how do you, as a clinician, then differentiate between somebody who might have, let's say, diabetes, who also has cardiomyopathy, and somebody who has cardiomyopathy because they have diabetes?
So again, you're talking to a cardiomyopathy doctor, right?
I am.
So the implication of that term, that is the way I interpret it, is saying you've got a bad heart because you drink too much, or because you're overweight, or because you've got... It's the same as saying hypertension or coronary disease. And of course, we see people who've got a dilated heart because they're alcohol intake is too high. The diabetic one is a little trickier because diabetes is not that uncommon. There's a lot of basic science research to support the fact that there may be such a thing as a diabetic cardiomyopathy. But people with diabetes often have other things. They often have hypertension. They may have a bit of coronary disease.
Okay.
So I have a reluctance to some extent in using those terms because I think it's too easy to say, oh, it's all because you're diabetes, you're diabetic, or it's all because you drink too much. As I say, I'm very open with people, and I say, look, I'm a paranoid cardiomyopathy doctor. So my question is always, why do you have this? And I try to do exactly what I was saying earlier. Take the family history, I look at the electrocardiogram, I look at the echocardiogram, I look at the MRI. Is this all compatible with a diagnosis of alcoholic cardiomyopathy? If I've done that, but hang on a minute, but my two sisters died in their 40s from heart failure.
Yeah, so it's the family history again, isn't it? It's the whole picture.
It's what we sometimes refer to as these diagnostic red flags. Or you look at the MRI and there's a particular pattern of scarring which you don't see in alcoholic cardiomyopathy, but you see in inherited disease. Okay. Well, either it's got nothing to do with the alcohol, or it could be two things. Some of the cardiomyopathies that we see, again, particularly dilated cardiomyopathy, so there are particular mutations in a gene called titin, for example, which makes you much more vulnerable to things like alcohol consumption or pregnancy, or chemotherapy.
Yeah.
So you're more likely to develop a cardiomyopathy if you're exposed to those things. So these things are usually multifactorial.
Yeah. I hate that term.
I can't immediately think of an alternative.
It feels like the old, idiopathic. If we don't know what it is, we'll call it idiopathic. If we don't really know what's causing it, we'll call it multifactorial. I'm
happy with the term as long as you define what those factors are and explain how they interact with one another.
Okay.
I mean, we see this a lot in hypertrophic cardiomyopathy. So, about 40% with hypertrophic cardiomyopathy, we can identify a genetic mutation. What do the rest have?
Yeah.
In some will have genetic disease for which we just haven't identified the mutation. We keep on finding genes. So each of those new genes accounts for maybe 1% or less of disease, but there is still a story there. We have work from large populations which show that it relates to what we call polygenic inheritance. So in HCM, DCM, we're often looking for the single genetic abnormality which causes the disease. But in fact, a lot of disease is the fact that you've got variants in 50 genes or 100 genes, which individually don't cause disease.
Yeah, but together
you get them. And certainly, so there does seem to be a genetic predisposition to developing a thick heart or dilated heart in some people. We often see men who got sleep apnea or they've got a bit of hypertension, and they may fulfill the criteria of hypertrophic cardiomyopathy. They don't have a gene. What do we call that? Do we call it sleep apnea cardiomyopathy, or do we call it, middle-aged man who's overweight cardiomyopathy?
I wouldn't go with that one.
No, but that's what I mean by multifactorial. It's probably a combination of factors, all of which may lead to thickening of the heart. Is it the same as a 23-year-old who's got a clear family history of a genetic mutation? No, it's a different disease.
Yeah.
That's that why question again.
Yeah, definitely. And I think maybe for the guys listening to this podcast, like the take home there is, if you don't know why, you need to go and find out what the why is. If it's possible, yeah. But at least if the answer is we just don't know, it's kind of still an answer, isn't it?
Yeah. That's where we can say, look, sometimes I'll say it's about balance of probability. So I use the word think. So, based on what I've seen, I think this is the most likely diagnosis is this. Can't be absolutely sure about that. And then you have to talk through the implications of that. So if you've got your middle-aged man who's got a bit of hypertrophy and sleep apnea, one of the big questions there is, okay, well, we'll manage your condition according to your symptoms and so on. Should we screen the family? That's often a tricky one, actually, because everything is telling me from experience and what I'm seeing is that this is probably a bit of hypertension, a bit overweight, a bit of sleep apnea.
Yeah.
So do we then ask the family to keep coming back for repeated screening? The emerging evidence is that's probably not cost effective, nor is it clinically effective. You're not going to save many people from a bad event by doing that.
Okay.
But it is quite nuanced. If the ECG is a bit crazy and looks more cardiomyopathic, or if the MRI's got some funny scar, okay, well, maybe you're the one that we do need to follow.
So you talked there about tests.
Yeah.
So we're talking about ECGs, echoes, MRIs. Talk to us a little bit about those tests and what they tell you, and do you need to do all of them?
So I would say for cardiomyopathy diagnosis, the minimum is you've got to have a picture of the heart.
Yeah.
So good quality echocardiography, absolutely. I would also say that the ECG is a must, because it's often much more sensitive to early disease than an echocardiogram.
Okay.
That's my old-fashioned cardiology hat on. But
what do you see that indicates?
You can see, so ECGs are often about pattern recognition, in fact, largely about pattern recognition.
Yeah.
So in some diseases, for example, ARVC, the diagnosis may be entirely based on the electrocardiogram. Because on an echocardiogram, you won't see anything, because the features that are present within the heart muscle may be too subtle to be seen on an echo.
Would you see that on an MRI?
You might. Yeah. And that's why, for ARVC, for me, an MRI is essential.
Yeah.
Particularly when you're screening family members.
Yeah.
Are
we still calling it ARVC?
There is still an entity that I would be happy to call ARVC.
Okay.
Which is a disease which is characterised by arrhythmia, largely confined to the right ventricle, predominantly affecting the right ventricle, characterised by replacement of the muscle by fat and scar tissue. That's where there's been a lot of confusion, is that term has been sort of stretched to accommodate people who've got nothing going on in their right ventricle and it's on the left side. And so we've had a whole variety of terms like arrhythmogenic left ventricular cardiomyopathy or arrhythmogenic dilated cardiomyopathy, and a lot of those terms they're not very helpful, to be honest.
Not helpful for patients, are they?
Or I think for doctors, because the why question then really is important.
Yeah.
Because does this person have a bad heart muscle, which is, we're seeing this in the left and the right ventricle, but it's actually being caused by a mutation in this particular gene, a desmoplakin mutation. Because then the management depends on how do desmoplakin mutations behave? What is the risk of sudden death with mutations in this gene? Is this person likely to develop heart failure in the future? Well, they might with this gene, but not in another gene.
Yeah.
That's the why. Why is really important in dilated cardiomyopathy.
It's so going back to the original question some time ago now about description over diagnosis, it's the devil is in the detail.
Very much.
Isn't it?
Very much. I mean, you're aware that 2023 we had the first cardiomyopathy guideline from an international society.
Yeah.
We've had hypertrophic cardiomyopathy guidelines before, but this was all the cardiomyopathies, chaired by Juan Pablo Kasky at Great Ormond Street. And this concept, this approach to the why, and pervades the entire document. Cardiologists are simple souls.
I don't believe you.
I know. It's false modesty. But putting things into boxes is sort of, it makes our lives a lot easier, but it isn't precise enough to be able to define management plans and to advise people and families, in my view.
And people don't fit into boxes, do they?
They don't. And it's not the argument that it's sort of there in the guideline, but if I have to defend it in public, it's much more about a narrative. So when I'm writing a letter, I don't just say this person has DCM or HCM. I'll actually describe what they have. So this person they've presented ventricular tachycardia, they have a family history, his father died when he was 23, or 23, 43. We found scar on the MRI, he carries this variant. So this person has a cardiomyopathy caused by a desmoplakin mutation. The treatment therefore should be X, Y, and Z. I've been doing cardiomyopathy a long time. It doesn't matter to me whether you want to call it non-dilated left ventricular cardiomyopathy or arrhythmogenic dilated cardiomyopathy. It's the why, because that determines. But it's quite a difficult message to get out there.
It's kind of old-fashioned medicine, isn't it?
Really? Do you know, I often say that. For me, there's nothing. We haven't reinvented the wheel here. This is about old-fashioned clinical method, which is about taking history, doing a physical examination, describing the tests.
And also, I think for people with the condition, I mean, you say it doesn't necessarily matter whether it's defined as this or defined as that. But I think when you have something, it does matter. And I think to the patient, it matters, because I think a lot of the time people might have lived with symptoms for sometimes decades and probably been told there's nothing wrong, or, you know, it's stress, or, you know, if it's a woman, it's because you're hysterical, you know, that kind of thing. And I think actually having a name that you can put, it really helps to sort of absorb what's being, you know, told you. And actually sometimes, even though we think that diagnosis is, you know, bad news, sometimes it's a relief.
Yeah, I think I was slow to that realization. I mean, I've been conscious of the importance of a label in the context of sort of young sudden death, for example. So there's nothing worse as a family to be told that your 17-year-old son died and we just don't know why.
Yeah.
You know, he's had a post-mortem, couldn't find anything. And in a way, that's why terms like sudden adult death syndrome and those kind of things were invented, because although we can't say precisely what, it's got a label.
Yeah.
So the family said, yeah, our son had SADS. So I get that. And I think that probably that it's true other things. You know, I've got all this because I have hypertrophic cardiomyopathy, or I have dilated cardiomyopathy.
Yeah.
So I see that. But again, I think it's a process of iteration. I've been seeing people for 20 or 30 years coming to this clinic, and the way in which we think about disease, the way in which we label disease has changed. So not infrequently, I'll find myself sort of going through that update. And that it can be jarring, because we've managed something in a particular way, we've now got new data, we've now got a genetic mutation we found.
Yeah.
Well, actually now, maybe we should start thinking about defibrillator. Wait a minute, you've been seeing me for 10 years.
Yes, why now?
Why now? And that, so because we think about it differently now. Now actually we know more about the why in you.
Yeah.
And this is what we need to do in response to that.
Do you think that the way in which you think about it and that iteration has been influenced by the advent of new medications, or did it happen independently of that? Because, I mean, until quite recently, it's been pretty much the same old drugs, hasn't it?
Yeah, pretty much. Except, so I think the biggest therapeutic innovation in terms of drugs has been dilated cardiomyopathy.
Okay.
So, you know, we have the 4 pillars now. Yep. So, you know, we say ACE inhibitors, but Entresto, spironolactone, dapagliflozin, beta blockers. But so those drugs, you know, there've been lots of large trials which have shown that people who have impaired pump function, on average, do better each time you add one of those 4 drugs.
Okay.
So dilated cardiomyopathy, I think there's been a lot of innovation in terms of drug therapy. Hypertrophic cardiomyopathy, the reverse. So we've been using the same 2 or 3 drugs for decades, mostly in people that have HCM with outflow tract obstruction.
Yeah.
For people that don't have outflow tract obstruction, we use diuretics. We might use drugs like ramipril, the ACE inhibitors, but we've got no evidence really that they work in that situation.
And what are you trying to do with those drugs? So if you take the hypertrophic cardiomyopathy patient, let's say as an example, what are those drugs doing for that person?
I think there's 2 reasons to give someone a drug. One is to treat their symptom or symptoms, and the second is to improve their prognosis. So dilated cardiomyopathy, we use it for both. So the 4 drugs that I mentioned help symptoms, or it's help prevent progression or exacerbation, but they also significantly improve prognosis. In hypertrophic cardiomyopathy, we don't have drugs that do that, improve prognosis. They may help symptoms, but we don't have prognostic medication in HCM.
Okay. So,
but it's something I try to teach. You know, if you're going to put someone on a tablet, you've got to ask the question, why again?
Yeah.
Why am I doing this? There has in the past in hypertrophic cardiomyopathy been this reflex where HCM equals beta blocker.
Yeah.
It's a very old-fashioned way of practicing, but the trouble with doing that is it's no evidence that it improved prognosis. If the person doesn't have symptoms, you can give them symptoms by putting them
with a beta blocker. Yeah.
So am I going to make this person feel better? Am I going to make them live longer? Or reduce the likelihood of other complications like stroke, for example, in the case of atrial fibrillation.
Yes. So we do actually have a drug now, don't we, for obstruction and maybe non-obstructive HCM that changes the underlying mechanism of the disease in a way. Talk to us a little bit about mavacamten.
Yeah. So as a group, what are called myosin inhibitors. So this is a new class of drugs which were developed out of an understanding of the basic biology of hypertrophic cardiomyopathy. So at least in some genetic forms of HCM, at a cell level, what happens is the cell contracts more than it should. And as a consequence of that, the cell responds by enlarging, hypertrophying. So the idea was, well, if we can interfere with that hypercontractility, as it's called, we might be able to treat symptoms, but maybe even prevent the disease from developing. The first in class of that drug, mavacamten, has now been used in people who have HCM and symptomatic obstruction, who were being treated with other conventional drugs, beta blockers, calcium antagonists. And the bottom line is that maybe in just over a third, people felt a lot better, were able to exercise more objectively, and we have reductions in the obstruction and in markers in the blood which tell you the heart's under stress. There's now a second drug called aficamten, which works in a very similar way, which has shown virtually identical results. The exciting thing about those trials is that there's a suggestion that not only is it treating the symptom, could it be modifying the disease? In other words, could it change the natural history of the disease? Could it reduce the thickening? Could it reduce the likelihood of heart failure? And there's a signal at the moment that maybe thickness might be coming down a bit in some people.
Oh, wow.
And we have no other treatment.
Because that was something previously that was thought
impossible.
Yes, exactly. So once you've got a thickness of 14, 15, 16, you know, that's it for life.
Yeah. I mean, I don't want to...
That's quite miraculous, though, isn't it? Should we be really excited? Should we be really excited about this? I think we should.
So, I was saying about, constantly changing the discussion about these diseases. So if you'd asked me that 10 years ago, is it possible to reduce the hypertrophy by giving a tablet?
Yeah.
Is it possible to reduce scar by giving a tablet? I would say very ridiculous.
Yeah.
Now I'm not so sure. Yeah, time will tell. And I don't want to raise people's expectations that we're going to put them on mavacamten and then 6 months later I'm going to say you're cured of the disease.
Yeah.
But I think there are some early signals. And another almost miraculous thing is that some people who are going on to mavacamten, the ECG is normalising, which I would say was impossible. So
it's a fine line, this, isn't it, between actually being quite excited for what's happening and actually having some level of reserve about the future, because when nothing's happened in a disease for decades and then something suddenly happens and you've got something, it's very easy just to go, wow, great, we've got this now, we're going to give it to everybody. But actually, that's not necessarily the right way to go. It's not going to be effective in everybody. But it's a fine balance, isn't it?
It is a fine balance, but it is, I mean, I'm not one given to hyperbole, as you know, Libby, but it's, that horrible phrase, game changer, I think it is a game changer in hypertrophic cardiomyopathy, because we probably modify disease to some extent in dilated cardiomyopathy through the use of beta blockers and the other drugs. But I don't think we've done that at all with the drugs we've had in hypertrophic cardiomyopathy. This class of drugs work in a totally different way. That is genuinely exciting, and people do seem to be responding to the drugs. Yeah. And this is only the beginning of that story. So the companies that make these drugs are already working on son of mavacamten, or daughter of aficamten, to be sure that
we've covered all bases there.
But they're working on the second generation drugs, so they're trying to tidy up some of the complications of those drugs. For example, the big problem with aficamten and mavacamten is that they do reduce the contractility of the heart. Yeah. So that's why you have to constantly monitor the effect of the drug, frequent echoes, etc. So they're trying to tidy that effect up so that maybe it's less what's called negatively inotropic. Yeah. But focuses much more on how the heart relaxes. Yeah. Because the there's a lot to be potentially gained from focusing on that element of the disease.
I think it's really exciting. We often think about cardiomyopathies in our little boxes, as you said, so you've got this cardiomyopathy or that cardiomyopathy. What are the features that unite all cardiomyopathies?
Wow, that's quite a question. I suppose you could answer that question in different ways, couldn't you? I think they're all diseases they're descriptions which encompass a large family of different diseases. They affect people of all ages. They're all, to a large part, inheritable.
Mm-hmm.
Yeah, not everybody with DCM or HCM has an inheritable disease, but 40, 50, 60%, whatever cardiomyopathy you're looking at. So genetics and everything that comes with that is important to all of them. I think they're all, to some extent, frontier medicine. So we've been talking about one of those frontiers about therapeutics and hypertrophic cardiomyopathy. I think there's still an awful lot to be done in terms of understanding the physiology, developing new therapies to prevent disease progression.
Gene therapies?
Well, I was going to say they're all potentially preventable. I don't know, but it's like saying we can't reverse elements of the disease. Can we imagine prevention? Yes, I think we can now, because this is the ultimate prevention, right? If you can make a genetic diagnosis, so this person carries this variant, they haven't yet developed the disease. Can we, with what's now starting to come through, imagine a time where we can actually start therapy to stop it from happening? That's not such a crazy thing anymore.
I think one of the other things that unites all of the cardiomyopathies is the psychological impact of that diagnosis.
Yep.
How do you manage that in the clinic? Do you see much of that when you give a diagnosis, or is it something sort of the downstream effects that people might deal with on their own? I mean, how do you manage the psychological impact of the disease?
I think within the framework of how we deliver care at the moment, it's probably not dealt with very well at all. I said it takes 10 minutes to do a family history. To sit down with someone and really understand their emotional, their psychological reaction to a disease takes
a long time.
And it may not be one sitting, it may take several times. So the way I do it, I think, is to give... So I have a system, when people come in. I try to cover all bases. Again, I'm privileged in that people have usually been going through the system for quite a while.
Yeah, by the time they get to you.
Yeah. So a lot of people come quite well informed. So it's not often the first time they've been given a diagnosis when they come to my clinic.
Yeah.
But they've often had 10-minute consults before. You still hear the horror stories, and that, I went to an AE, I had atrial fibrillation, they did some tests, I went to the outpatient clinic, I was told in 10 minutes that, I've got hypertrophic cardiomyopathy, this is a disease which could kill you.
Yes.
Almost goodbye.
Yes. It has happened.
It happens, right? When I talk through it, I talk through all of the things that they've probably already read about. One of my many cliches is the Google moment. What do you find out? You find out dilated cardiomyopathy, you're going to be dead within 2 years.
Yeah.
Because those numbers are still out there, but that hasn't been true since the 1970s.
Okay.
You're going to find about footballers that have dropped dead on the pitch.
Always, yeah.
Yeah, and so, oh my God, I'm going to drop dead on the pitch because so-and-so died from hypertrophic cardiomyopathy or ARVC.
Yeah.
Everybody finds the same stuff. So my job is often to try to put that into context, to use the term, we were talking about the importance of terms like cancer and heart failure. Just say, let's talk about your risk of sudden death.
Yeah.
And what that means. And at the end of that consult, I think, this may just be what I'm imagining to make myself feel better, you can see people relax because no one's actually had that conversation before.
Yeah. I suppose it's the same thing as not wanting to give people a name, a label of cardiomyopathy. It's like, it's the elephant in the room, isn't it? This is the disease that causes sudden cardiac death. Do I address it or do I not? I think it's much better to get it out there and talk about it. And I think the risk calculator gives you that opportunity, doesn't it, to have that discussion.
One of the arguments against that kind of calculator approach is that, say, well, yes, no, based on a number, you're going to put in defibrillator or not. I don't use it that way. So I use it in that discussion about what does risk mean to you? Because those things may mean different things to different people.
Yeah.
You know, if I take 100 people like you, in 5 years' time, 5 of them may have died suddenly.
Mm-hmm.
That's a very different way of imagining risk.
Yeah.
To say you've got a 5% risk over the next 5 years. Well, that doesn't sound very much, does it? 5%?
Sounds quite high to me.
To you.
Yeah.
But to other people, not.
Mm. Because the other conversation is the risk of having a defibrillator.
Yes.
So there's the balance of that discussion.
There's always that balance. Yeah. This is a little difficult, though, because it's not... The scales are not equally weighted.
Mm.
So on the one hand, you've got the risk of dying against the risk of what could be very significant complications, infection, inappropriate shocks, and so on.
Yeah.
But it's not quite the same as death. But that's, in a way, not my decision. My role is to help someone understand the two sides of the balance and then come to a decision as to what's right for them.
Yeah.
It takes time. And it may not be possible in one sitting.
Yeah.
It may take 2 or 3 goes.
Yeah. We've chatted quite a lot today, haven't we, about quite a lot of things.
But we knew we were going to do that, right?
Well, we always do. But I think my last question is really one about looking to the future.
Yeah.
So I'm really sorry, I'm going to use the term game changer again.
Okay.
But there's been so many advances, let's say, in the last 5 years in the treatments of cardiomyopathy. What do you think is going to be the game changer over the next 5 to 10 years in this world?
So I suppose what I hope I'm seeing in transition is a genuine move away from DCM, HCM, ALVC to saying, bad heart muscle, you have a desmoplakin cardiomyopathy, or you have inflammation, you have myocarditis. More personalised diagnosis with implications for personalised treatment.
Do you think that's going to happen in the next 5 to 10 years?
I think it's already happening.
Oh, do you?
I think it's already happening.
So much to be hopeful for, isn't there?
Very much.
I think at the end of our first ever podcast, it's really nice to have something that's just really positive and really great to hear. Perry, a pleasure, as always, to talk to you. Thank you very much. Thank you for being our first guest. And I think we'll talk again later in the podcast series. And thanks very much.
Thanks very much. I enjoyed it.
Thanks for listening to this episode of Cardiomyopathy Conversations. Please remember, any medical information contained within the podcast should not be used as a substitute for advice from your own doctors. If you have any concerns over your own condition, please do consult your medical team. Views expressed in the podcast do not necessarily represent the views of Cardiomyopathy UK, but are the views of the individual host or speaker and is intended for a UK audience. Cardiomyopathy UK does not accept responsibility for any actions taken after listening to this podcast.